the differences between regular first aid in a workplace environment and what you would do in a healthcare provider course. So mainly the theory differences. There's a few different things that you do differently in a healthcare provider course as opposed to a regular workplace first aid course that's outside of what healthcare providers do. A regular first aid course would be something like standard first aid with CPR level A, for example, and a healthcare provider course would often be something like standard first aid with basic life support, BLS, or we used to call this HCP, healthcare provider level, CPR and resuscitation. Most of the differences between your basic first aid course, and your healthcare provider level are going to be in the resuscitation section. Your resuscitation section in a traditional first aid course would be roughly an hour to an hour and a half in length. When you do a adult child infant course, it's more an hour and a half to 2 hours. In a healthcare provider or basic life support level, you're looking at 4.5 to 5 hours. It's more than twice the length, potentially 3 times the length of the other version. There's a lot of different stuff. So when you're looking at the pre-resuscitation stuff, there is one big difference. In your traditional first aid course, the age ranges that are relevant are going to be 0, 1, 8. So 0 to 1 being infant, 1 to 8 being child, 8 and above being an adult. In the healthcare provider level or in basic life support and above, you're going to be looking at 0, 1, puberty. There is puberty assessment in healthcare provider level first aid. The assumption is that a healthcare provider can reasonably assess for puberty. Even though this is a difference, practically speaking, the difference between this isn't as important because you're largely looking at body size for a lot of this. When we get into resuscitation, there is a pulse check on an unconscious casualty with healthcare providers. There is not with non-healthcare providers. With regular first aid and resuscitation, the assumption is that the layperson cannot realistically find a pulse on someone who is unresponsive. It's not practical to expect them to be able to find one. It is very possible that the layperson in a panic would, check for breathing, would find breathing, and would not find the pulse simply because they just can't reliably find it. And then they have to say in their brain, okay, wait a minute, their lungs work, but their heart doesn't work. What do I do? And the reality is that that doesn't really happen. If they find that, it's because they didn't find the pulse. And a layperson panicking would probably just start CPR on somebody that is breathing, which you don't really want to do. So yeah, there's that distinction that is made. When you are doing your standard ABCs assessment at the beginning of a primary survey as a healthcare provider, in the head tilt shin lift, there is a simultaneous pulse check. So there's a head tilt shin lift with pulse check on carotid at the same time. This is something that needs to be practiced. Once again, not something you're teaching the layperson. So that's one major difference. Everything else is in resuscitation. Wound care is the same across all these different first aids. You don't do wound packing in a first aid environment. Even as a healthcare provider, it isn't trained. You don't do tourniquets, depending on jurisdiction, actually aren't even included. Sometimes they will be in a more advanced course, but the only difference is resuscitation. Let's talk about resuscitation. So resuscitation for healthcare providers or for basic life support for BLS. So resuscitation with basic life support differences. In regular first aid, the magic ratio for compression to ventilation is 30 to 2. 30 compressions, 2 ventilations. Adult, child, infant, multiple rescuer, single rescuer, doesn't matter. It's always 30 to 2. In healthcare provider level, in addition to CPR, cardiopulmonary resuscitation, you also have AR, artificial respiration. Regular first aid does not have artificial respiration. If the person isn't breathing, they just start CPR. They don't only do breaths. Also, with regular first aid, the assumption is that they're not very efficient when it comes to getting between compressions to breaths to back to compressions. So they don't change the rate because they want them to get back to compressions as soon as possible without interruption. In fact, in many cases, they will recommend that they just skip 30 to 2 altogether and go on to compression only, and they don't even do breaths and they just hit the chest. And they will do this for someone who isn't breathing and has a pulse because they're not checking for a pulse. They don't know if they have a pulse or not. They just assume no breathing equals no pulse. These are going to be very, very different. So once again, this right here, this 30 to 2 compression only type of deal with only CPR, that's regular. With healthcare provider level, this is going to get very different. I'm going to erase the irrelevant information here. With healthcare provider level, or with BLS, you have different ratios that will be used depending on the type of casualty and how many responders you have. The way this will work, you'll have basically 1 or 2+ rescuers. So you have 1 resc, and then you have 2+, and then you'll have adult, child, and infant. And the ratios will be different depending on the differences here. An adult is going to always be 30 to 2 regardless of number of rescuers. 1 rescuer CPR is always going to be 30 to 2 regardless of age range, puberty, etc. Because children and infants have higher base heart rates and require faster compressions. They burn through their oxygen faster. You'd want to reintroduce oxygen quicker. The 4 to 6 minutes until brain death concern begins with lack of oxygen is closer to 2 to 3, the closer to infancy a person is, because of those factors, and because with 2 or more rescuers, you can minimize the interruption to compressions when you're doing breaths. 2+ rescuer, child and infant is a ratio of 15 to 2 instead of 30 to 2. This requires you to be much faster at going between compressions and breaths to minimize those interruptions to compressions than the lay person would be with a standard, adult resuscitation workplace first aid course that they're taking. So this is different. When do you do artificial respiration? When do you do CPR? This again is another sort of chart. We're going to do artificial respiration on an adult when the person is not breathing, but they have a pulse. No breathing, yes, pulse. You're going to do CPR on an adult when no breathing, no pulse. With child and infant, this will change. You're going to have still no breathing across the board. Actually, for the sake of argument, this is all no breathing. So I'm just going to erase no breathing because it's all implied. All of this is no breathing. So you don't need to think about that information because that's always the same. You're doing some sort of resuscitation. If they're not breathing, you know that. Yes pulse versus no pulse for AR and CPR for adult. For child, the question is the pulse greater than 60 beats per minute? Or is it less than 60 beats per minute? Same thing with infant. So with an infant and a child, it's not whether or not they have a pulse, it's whether or not it is high enough or fast enough. Because their hearts beat so quickly, average heart rate of a human, 220 minus your age is basically the assumption. That's kind of like your maximum heart rate. And then you'd have, an average heart rate that's closer to your max based on your age. The older you get, the lower your max is, the lower your average goes. If your pulse is this low, as a child or an infant, the assumption is it's so low that it might as well not be there and they need CPR anyways. So you're checking for a pulse and you're caring about the rate. Now, how do I know, is 60 fast enough, slow enough? How do I check a pulse for, beats per minute in 10 seconds? Because your head tilt chin lift breathing pulse check is going to be 5 to 10 seconds. Normally if you're going to do an accurate pulse check, you'll do 15, 30 seconds. Because this number is 60 and there's 60 seconds in a minute, all you need to do is have access to accurate second counting, and you have to see if the pulse is beating faster or slower than seconds are counted. So if you count to 10 with accurate seconds on a watch or something, and the pulse is beating faster than you're counting, it's above 60. If it's beating slower than you're counting, it's below 60. You don't really need to think about this in any way that's more complicated than is it going faster or slower than a second count. That's it. Is it faster than a second count and they're not breathing? You're doing artificial respiration. Is it slower than a second count and they're not breathing? You're doing CPR. That's it. Don't overcomplicate it. This is something in a first aid course that you would want to practice a lot. You need to get a feel for this generally, especially if you're not someone that works in cardiology or emerge, or like paramedics would do this more. Frankly, a lot of the time in the Western world, you have machines that check this for you, so you don't do it manually. So very often people that, even do check heart rates very frequently, they're not doing it manually, they're doing it with a machine that's automating it for them. So people might be out of practice for this. In first aid, the assumption is you don't have a machine and that you have to do it manually. So this can require some practice. Okay. This is the bulk of the major theory that you need to consider with healthcare provider, as opposed to with what you would do not outside of healthcare provider when it comes to figure out what I'm going to do, where I'm going to do it. When looking at artificial respiration and CPR, so when looking at the breathing component especially, in healthcare provider level it will change. With the layperson, they will probably not be using a BVM, a bag valve mask. With healthcare provider, you're supposed to know how to do mouth to mouth, pocket mask, BVM with holding with a seal with a CE clamp, which I'll show in a bit. So there's a CE clamp that you hold to secure the mask. You generally are supposed to learn how to do it with one hand and two hands, because when you do single rescuer or even two rescuer CPR, one person has to be able to secure mask and squeeze bag, which means you have to do a one-hand seal. When you're doing three rescuers plus, then like you can have two hands on one and one person can squeeze the bag while the third is doing CPR, right? But you need to know how to do all this different seal work to seal the mask to the face. And then also what is often taught is something called a jaw thrust, where the jaw is manually taken out of regular alignment so that if they have a head and spinal injury with a CPR being required, so if you have a heart attack and it causes you to fall off a ladder or something, so you can't head tilt chin lift because of the spinal injury, or you don't want to have to, the technique of moving the mandible out of the way so that you can open the airway without moving the spine, and how you get that seal, because that seal isn't a standard CE clamp. CE clamps do a head tilt. The jaw thrust clamp is different with the moving of the mandible out of the way. That is not something they teach in basic first aid. That's basic life support and more advanced life support exclusively. That's different. So this is all going to change quite a bit. There's one more thing, which depending on what level, sometimes this shows up in a more basic first aid course. Sometimes it will show up in your child and infant level, but certainly this last part will be in healthcare provider level. I'm going to erase again to explain that. There is something in responding to a emergency situation where the person has stopped breathing called witnessed or unwitnessed unconsciousness. And the idea is that when you observe somebody go unconscious, you know when the 4 to 6 minutes from lack of oxygen to the brain and then brain death starts occurring, you know when that timer starts. So when you know when that timer starts versus when you don't know when that timer starts, it will change the way you'll resuscitate. For example, if you come across somebody who is unconscious and not breathing, and you cannot call for an ambulance and begin CPR, you have to choose one. If you just witnessed them go unconscious, the general protocol is call an ambulance, return, and then start CPR. If you can't, just put them on speaker and do it at the same time. If you can do it at the same time, you do it at the same time. But if you have to make a choice, you prioritize calling instead of resuscitating. If it is unwitnessed, you don't know how long they've been down for, then what you do is you prioritize giving them 2 minutes of CPR, then you interrupt, then call, and then come back and return for CPR. The reason for that is because you need to reset the timer basically on brain death, or at least pause it and give some new oxygen to their system. At healthcare provider level, it is assumed that you can make that sort of judgment call. At the beginner level, sort of a first aid for the layperson, they might not even teach that, depending on what jurisdiction you're in. That number also kind of changes when it comes to infants and children. With infants especially, because you're looking at 2 to 3 minutes before brain death starts, it's such a large concern. Generally speaking, they just say do 2 minutes of CPR anyways, unless you literally just saw it happen and the phone was in your hand. because you want to reset that timer as early as possible. This whole judgment call of, do you need to reset the timer now or later? That discussion, that thought, it's assumed that you are able to think about that and make that judgment call at the healthcare provider level. Basically, consider 4 to 6 minutes or 2 to 3 minutes until brain death begins, depending on age. Figure out, do I have the time to make the call, or do I need to start resuscitation to reset them now? And make the best judgment call you can, is the theory and idea behind that. That is in healthcare provider level basic life support, and that is not something that a layperson may be familiar with. There is also, so I'm going to kind of step back now from how we look at what sort of thing that we're doing, and I'm going to give you the difference in theory that you would have between your basic first aid course and your healthcare provider course. Your basic first aid course will have heart attacks, they will have strokes, they'll have angina. They'll make usually some distinction between TVA and CVA, so stroke and mini stroke. They'll give them the longer names for things, transient ischemic attack, etc. But they don't put a big focus on making sure people remember these things. They will basically say that all of these things are caused by a clot and that clots are bad, and then say, by the way, 911 and CPR for everything. They'll give some further explanation on the sorts of signs and symptoms people might want to look out for a heart attack. So, basically they'll say anything between the jawline and the end of the digestive system that persists for more than 4 to 6 hours with consistent pain that doesn't radiate. So chest tightness, lack of appetite, arm pain, back pain, whatever. They'll go through a whole list, and then they'll generally recommend some sort of external resource like Heart and Stroke Foundation where they can go learn more information. So that's pretty much what's done in a basic first aid course. They might go over chain of survival, where they talk about you have to make sure that you've got your CPR, you've got to do early recognition, ambulance is important, like they'll go through all that, but you're not getting into anatomy as much, and you're not getting into the mechanics of how certain things work. In basic life support, there's a bit of anatomy. This is kind of intro level. This isn't going to be what you learn in a nursing program, but it's certainly more than you get in a basic first aid course. So when you're looking at anatomy, they're not going to go over respiratory system in the lungs, but they will go over the heart. When they go over the heart, what will generally be done, either in video form or through writing on a board, is they'll draw a heart out. There's going to be an emphasis on the left ventricle sticking out. So they'll draw a heart. There's going to be the left ventricle sticking out. When they're looking at the board, because we're mirroring this video, I don't know how this is going to look on your end, but basically you'll have the left ventricle which sticks up, the right ventricle, and you'll have the left atrium, and then you'll have the right atrium. They may talk about the aorta. They may go through some certain vein systems, difference between an artery and a vein, but that's not usually the main focus. Once they draw this out, usually what will be talked about is where the pacemaker is and how it works, because this informs how defibs work so that you understand kind of the mechanics behind it. So there will usually be a drawing of the SA node with a reference to it up nearby the right atrium, and there will usually be a drawing of the AV node and a reference to it towards the center. After that, to explain the way electrical conductivity in the heart works, it's like when electricity is sent through the heart, or when your regular neurological signals are sent through the heart, the signals come in through the SA node and they're regulated through the AV node, and the heart beats in 3 directions. It's more than 3 directions, but the distances are different because these are different distances. So the heart needs to beat from the right atrium to the left ventricle. It doesn't necessarily beat like that, it beats like this. So that sort of movement. When this is explained, and the reason why this becomes important, and the reason why we focus on this a bit more in healthcare provider level, is because the pads for the defibrillator are supposed to be up top and below, because when you shock, it's supposed to shock along the same line of the SA node, bringing the electricity through the heart. When someone has a pacemaker installed, it replaces their SA node in practically speaking. This is a distinction that's made in a basic life support class. Keep in mind that these sorts of classes, these BLS courses, will often be required for nursing program. This might be a prerequisite to go into the program, so it's very possible that this is one of the most advanced one of the students has seen in cardiology and anatomy, because they may have come from a high school program where this is actually more advanced than what they've previously seen. But there may also be someone who's a veteran nurse that's been working in cardiology or in Emerge for 20 years in the same course. And that nurse, this is absolutely something they've heard forever. They've probably taught this. This is not news to them, right? So that's the pathway it goes along. And when we talk about irregular heart rhythms, in a regular course, they'll just say the defibrillator knows, it'll figure it out. In a basic life support course, we talk about fibrillation and tachycardia. So with fibrillation, the heart quivers, and basically these signals that are going at different distances are not being regulated correctly. So instead of this going together, it's kind of going a bit here and then a bit here, and it's kind of like shaking instead of beating. That is one type of irregular heart rhythm that the heart will shock. The second type of heart rhythm that a defibrillator will shock is tachycardia. That's when the heart is beating too fast. If you have a different type of heart rhythm that isn't tachycardia, a shock will not be necessary. A shock won't work, basically. So heart beats too slowly, shock won't work. Asystole, heartbeat is off, shock will not work. If you see movies and TV shows where the person flatlines and they start shocking, that's not what you do. They pump adrenaline. You don't shock a non-beating heart. Defibrillators essentially reset the heart rhythm so the heart can start beating again. They set you to 0. If you're at 0 and I set you to 0, it isn't really doing anything. That's the idea. In first aid, they'll talk about fibrillation and tachycardia. They may reference asystole, but usually they don't, even in the healthcare provider course. Other heart rhythms they don't even talk about. Most first aid instructors, frankly, don't know they exist. Like they don't know the name for them. That's not in the curriculum for what you have to teach. So they've never come across it. They don't care. They just know that there's the 2 that you need to shock, and all the other ones are irrelevant because they're outside the scope of first aid. That heart piece is provided to healthcare providers. That's all that's really gone for them. And then you get into specifics of how to do certain techniques. And that's not like theory on a board. That's how do we do artificial respiration? How do we do CPR? How do we do switching? Stuff like that. There's one more aspect that you technically could put on a board, and that would be when you're doing artificial respiration, how long should the time be between the breaths? So if you have an adult, you have a child, you have an infant, you should ideally do 1 breath for an adult every 5 to 6 seconds, 1 breath for a child every 3 to 5 seconds, and 1 breath for an infant every 3 to 5 seconds. But the way we normally remember this, to be frank, is with 5, 4, 3, 3, 4, 5. We just count to 3 seconds, 4 seconds, and 5 seconds and do it that way because it works in the range and you don't have to worry about it so much. So that's generally what we do. It's easier. There is one other thing. This is somewhat implied in the previous part where we talked about needing to know about, is their beat per minute more than or less than 60 when it comes to do I do artificial respiration or CPR on an infant or a child? So this relates to that. This is actually not relevant in general. Like this doesn't matter because as long as you knew the counting rate and where to go, you would do the correct thing in first aid anyways. So this information I'm about to give you doesn't actually affect how you treat in first aid. It supports why you would do what you did. And it is something that is taught, but it doesn't change anything as far as first aid is concerned. It will change things in healthcare when it gets more advanced, but in this it doesn't. And that is the average breathing rate and heart rates for your different age ranges. And the heart rate in particular is the one that's almost always taught. So you have 60, 80, 120, and 150. And the way this works is this range is adult for healthy resting heart rate. This range is child, and that range is infant. Now, the reason why child is 80 to 150 is because you would expect a 7-year-old or a child that's closer to puberty to have closer to the adult range, and you would expect a 2-year-old, which is closer to infant, to have closer to the infant range. So the child range is much wider. If you're looking at base heart rate, your resting heart rate, something between 60 to 80 is what you would expect for an adult that is healthy and at rest. Now, a marathon runner will be below 60. So like certain people will be below 60 generally, but this is your average general range. With a child, you're looking at something between 80 and 150, and the infant, you're looking at something between 120 to 150. Once again, if you found an infant with a resting heart rate of 110, it doesn't change anything because in first aid, it's above or below 60 and everything else is irrelevant. It doesn't matter to first aid. It matters for medicine and for like long-term conditions, but for the first 10 minutes, am I calling an ambulance? You don't care. Like this isn't relevant. In more advanced emergency medicine, it is relevant, but in first aid, it's not. But regardless, they do include this in first aid courses for basic life support because it's good to know, it's good to have an easy reference for this. And when you're going into healthcare, first aid reinforcing this can't hurt, basically. For breathing rate, I know the reason for adult is why it's 5 to 6 is because it's 12 breaths per minute and 60 seconds divided by 12 is 5 seconds. So they're looking at your expected per minute, is that the way it works? And this and the child and infant multiplies out the same way. I'm forgetting the exact number for adult, child, infant for expected breathing rate. I'll find it and we'll just include it here as a picture. We'll just add it in. Thanks, John. When you're checking for breathing, if you check for breathing for like 5 to 10 seconds, let's say you check for 10 seconds and there is no breath, but then they did one breath like after the 10 seconds. So they were doing one breath every like 12 seconds or something and you missed it. While they are still breathing, they're breathing so slowly that they might as well not be breathing. So the reason why the breath check is 5 to 10 seconds is because you're expecting a breath to come in every 5 to 6 seconds naturally. And if they, for example, just breathed and then you just started checking, so you just missed it, you wait, 6, 7 seconds, another one should have happened by then. So even if like your assessment is as unlucky as possible, because you've waited a long enough time, there should have been another breath. You don't need to know the magical breathing rate numbers that are optimal. You just need to know, check for 10 seconds. If I didn't feel one, they ain't breathing. And if they are breathing, they ain't breathing enough, right? So the theory reinforces why we do this, but as long as you remember what you're doing, it'll all work out anyways. And that's the bulk of the theory. The rest of this is fine-tuning demonstrations on how to do specific things, which will definitely be in a different video. We'll probably do it with one or more other people to demonstrate, because with multi rescuer, CPR and artificial respiration, you need a lot of people physically to show this.